The House Insurance Committee will come to order. Mr. Clerk, will you please take attendance?
Chair Harris,
Here.
Representatives Tisdale, Leitner,
Here.
Posthumous, Aragona,
Here.
Nyer,
Here.
Schutte,
Here.
Carter, Tate, Fitzgerald,
Here.
Whitsett. Mr. Chair, you have 6 members present, a quorum.
Thank you, sir. I appreciate you, Mr. Fitzgerald. All right. Can I have a motion to approve the minutes from the June 11th meeting? And Rep. Nyer will do that for us. Makes that motion. Seeing no objection, the minutes are approved. All right. Today we will be hearing from the DIFS fraud unit. Insurance fraud affects everyone. One of the purposes of this committee this year has really been to address cost drivers and things that are really impacting the consumer and our taxpayers, and affects our everyday premiums and costs for an awful lot of things. So it's estimated that about $80 billion a year across all insurance industries are what we're paying for in fraud. So this issue obviously impacts insurers' ability to serve their customers, as well as what people are paying for their premiums. So with that, as the committee dives into this issue, we're excited to kick things off with the department. And if you folks want to come up, I'll let you introduce yourselves since you have a big crew. And the floor is yours. You guys can start whenever you're ready. Thank you for being here.
Good afternoon, Chair Harris, members of the committee. I'm Jenny Geese, Legislative Liaison Manager for the Department of Insurance and Financial Services. Thank you for the opportunity to present on DIFS Fraud Investigation Unit and related legislation to help DIFS further uncover, enforce, and deter insurance fraud. With me is Joe Garsha, to my left, stage right, no, Senior Deputy Director and General Counsel for DIFS, who also oversees our fraud investigation unit. And to my right, Jennifer Kinsey, Regional Manager, who manages our investigation team. We've been working with the chair and some of the members of committee on ways to lower insurance costs, which is accomplished by addressing insurance fraud. To give you some background on the impact of insurance fraud, consumers and businesses throughout the country, including those in Michigan, are directly impacted through increased premiums. A study conducted in 2022 estimated the total cost of health and life insurance fraud and a few other lines in the United States to be at $308 billion per year. Separately, the FBI estimates that over a 10-year period, insurance fraud costs the average U.S. family between $4,000 to $7,000 per year in increased premiums. For every dollar of fraud, businesses incur nearly $3 in cost. So insurance fraud increases the cost of everything you buy and use. Every company providing goods or services pays for insurance as a cost of doing business. We know this. As a result of insurance fraud, the insurance companies are forced to raise rates charged to consumers and businesses. To cover the increased cost of insurance, Michigan businesses then must charge consumers more for their goods and services, like this unfortunate cycle. Joe Garsha will provide some background on the fraud investigation unit and how it works to uncover insurance fraud.
Thank you, Jenny. So my piece of the presentation this morning is a little bit of kind of background of how the FIU came to be, kind of its origin story, and some high-level details of how we operate. The Fraud Investigation Unit was established within the department in September of 2018 by Executive Order 2018-9. It was subsequently codified into law, into the insurance code in June of 2019. For those of you keeping score, it's in Chapter 63 of the insurance code. The FIU is a criminal justice agency within DIFS and is presently comprised of 12 full-time FTE employees, 2 managers, 6 investigators, 3 analysts, and 1 admin support staff person. The FIU is dedicated to the prevention of criminal and fraudulent activities in the insurance and financial services markets and performs in-depth analysis and investigation of reports of suspected fraudulent activities, and operates together with support and coordination from law enforcement agencies at the local, state, and federal levels. The FIU also seeks to deter criminal and fraudulent activities through collaborative efforts with industry partners, educating the public on current fraud trends and schemes, and by encouraging the reporting of fraud to DIFS where appropriate. In 2020, the Michigan Insurance Fraud Task Force was officially formed by way of a memorandum of understanding that was entered into between the three principal departments, DIFS, the Michigan State Police, and the Department of Attorney General. The goal of the task force is to promote coordination, cooperation between the three member departments in the investigation and the prosecution of insurance fraud in Michigan. Additionally, the FIU monitors and participates in the National Association of Insurance Commissioners Anti-Fraud Task Force, of which I'm a participating member. And where the multiple states with fraud units coordinate their efforts in the space of fraud detection and prevention. And now for more of a kind of boots on the ground synopsis of the day-to-day operation, I'll turn things over to Jennifer Kinsey, who supervises our investigative team.
Good afternoon. The Fraud Investigation Unit investigates all persons, including but not limited to persons subjects to DIF regulatory authority, consumers, insured, and any other person allegedly engaged in criminal and fraudulent activities in the insurance and financial service markets. Reports of suspected insurance and financial fraud can often be very complex and involve multiple parties. Complaints are reviewed and investigated to determine whether sufficient evidence exists to move forward with prosecution. Since the FIU staff are not police officers in their current positions, we partner with law enforcement agencies as necessary during an investigation. This includes law enforcement agencies at the local, state, and federal levels. Mainly, the FIU utilizes law enforcement to sign warrants and to make arrests. We will also ask law enforcement to assist us with interviews when we know a witness and or person has a known criminal violent history. After completing an investigation, the FIU makes a formal referral for criminal prosecution to local law enforcement agencies, the Attorney General, or federal law enforcement. During the last reporting period, the FIU's dedicated efforts to investigate suspected fraudulent activities in the insurance and financial markets resulted in 8 criminal convictions with court order restitution and fines and costs in excess of $840,000. Since September of 2018, the FIU has referred over 158 cases to the Attorney General or local law enforcement for criminal prosecution. To date, those referrals have resulted in 58 convictions for criminal and fraudulent activities in the insurance and financial service markets. Statistics are detailed in the FIU's annual report, which will be released soon.
And I'll just add, in front of you, you have the 2024 Fraud Investigation Unit's annual report, and this summer we're looking to release our 2025. So just as a FYI, and we'll share that with the committee once we have that finalized. So, well, as a result of the work the Fraud Investigation Unit has already done, we spent some years developing a bipartisan bill package with the goal to further uncover, enforce, and deter insurance fraud. While we don't have the 7 bills in front of us right now, I can speak briefly to them and provide a preview if that's all right with you, Chair. So just some brief summary of some of the bills. Our kind of first bill we've been working on is deals with information sharing. So under the current law, DIFS can share information with other states, but only if they request the information first. So we have a bill that amends the insurance code to allow DIFS to share this information regarding suspected insurance fraud with the National Insurance Crime Bureau. We also have a bill on kickbacks. So this amends the Health Care False Claim Act to include automobile insurers providing PIP coverage in the definition of healthcare insurer. This would make them subject to the anti-kick provisions of the act, like health insurance, for example. Then we also have racketeering. We have a bill that would amend the penal code to add insurance fraud to the definition of racketeering. This just would mean that insurance fraud activities would be included. Then we have the tiered criminal penalties. This gives prosecutors the leniency to offer lower penalties, such as a misdemeanor or lower felony, so that that way we can get information that could be exchanged for a lighter sentence to go over bigger fish. That's something that we've been trying to strive for those larger multi-state insurance fraud scams. And then we just have a sentencing companion bill to those tiered penalties. And then lastly, we have a bill on fraud reports. This creates a new section in the insurance code, which would require insurers in Michigan to file a fraud report with DIFS if they reasonably believe or know that a fraudulent insurance act has occurred. The goal is to unsilo information and see the broader fraud picture, which kind of goes back to that multi-state going after multi-state scams. So we've been working with the industry on these bills. We've been working with our partners, with MSP and the Attorney General. And overall, we believe these proposed changes are common sense amendments that will make the fraud investigation unit more effective. So in closing, fraud perpetuated in the insurance and financial services industries, affects everyone and costs Americans billions of dollars each year. The fraud investigation unit's approach is a multifaceted way to address the prevention of criminal and fraudulent activities in the insurance and financial services markets. And these bills aim to bolster that approach so we can continue to lower the insurance premiums for consumers and businesses. So again, thank you for your time. We respectfully support, these bills when they come before you in committee. I know this is maybe a little bit more unorthodox, but we're happy to answer any questions.
Awesome. Thank you guys for being here and for the committee members. If you haven't had a meeting with these folks yet, it's pretty exciting to, at least maybe I just find it exciting. So, I mean, it could be just me, but the fraud stuff just across the board is something, maybe it's the old cop in me, but I appreciate all your input. With that, we'll open it up for questions. I believe Majority Vice Chair Tisdall has something riveting for us.
Yeah, absolutely. Thank you, Chair Harris. Back in the 90s, there was a buzzword, re-engineering. And it was to, instead of identifying a problem at the end of the process, it was going back into the process and see if you couldn't prevent the problem from occurring in the first place. Obviously, the fraud is an investigation after the fact at the end of the process. Are there means of using artificial intelligence in the underwriting process up front to identify patterns of those more probable to commit fraud? And would there be limits in the amount of information that could be used so you're not alleging profiling or other discriminatory methodologies in order to identify these particular, the consumer insureds, right? On the front end, that would seem to be of interest to me rather than trying to figure out how to deal with it after it's occurred.
To address, just for the fraud investigation unit, the use of AI isn't used, but that's like on the back end. I will let Joe answer the use of other AI.
So, I mean, as it pertains to the use of AI specifically, I don't know that those conversations or explorations have been had directly with industry in terms of tools available at the underwriting stages to be able to kind of root out some potential future problems as they pertain to fraud. I do think that there is, outside of the construct of AI specifically, I think there is some additional work that potentially could be done at the company level on the underwriting side to help identify or potentially eradicate any future problems through the underwriting process. I will say that the fraud investigation unit, in the normal course of our operation, we engage quite regularly with company-specific SIUs, their investigatory units, their in-house investigatory units, and that dialogue is ongoing. And so we also participate with industry trade groups. MIASU is a perfect example. It's an association of SIUs that get together and talk about fraud trends and things of that nature, and we help collaborate with them within those settings to try to identify additional tools to utilize.
If there could be more done on the front end in the underwriting process, what's preventing that now? Is it simply a cost benefit thing, or again, are there taboo pieces of information that prevent more of that from happening?
Representative, that would probably be a question best posed to industry
I'm looking for
folks.
answers now. No. I'll give you 6 minutes.
I suspect the answer is likely a blend of what you touched
Okay.
upon there. I think it's a consideration on both sides of that particular issue in terms of, the profiling concerns potentially.
It's just a habit I've gotten into. If we're investigating issues at the back end, the next question is, well, what can be done at the front end?
Sure.
Rather than, you used to test cars at the end of the assembly line and then fix them from that point forward instead of going back into the assembly line, seeing where the problem started originally.
Yeah, I will say, I mean, some of the, I guess, front-ended concerns, the way within which FIU tries to address some of that at the front end as opposed to on the back end investigating acts that have already occurred. We try to address a lot of that through some of our education and outreach components, right?
Yeah.
Trying to, because candidly, there's this perception out there that insurance fraud really isn't a crime, right? It's just folks trying to get their money back or whatever the case may be, whatever their justifications may be,
Yeah.
right? It's a crime in a lot of people's eyes that's committed against, big bad insurance companies, right? So the education and outreach component is a large piece, and it's one directly within our control to participate in that process, and we're doing what we can to get the word out. As far as the specific tools, I think that's really an exploration directly with industry folks in terms of what they can and can't avail themselves of.
Yeah, you look at a large enough sample of those convicted, you could develop a profile and run through the multitude of characteristics on the front end and start to identify some of those and then possibly reject them, but make sure you're rejecting them in a way that doesn't run afoul with, oh, you can't use this characteristic or that practice or some of those things in the law, and maybe that needs to be adjusted with the modern technical abilities now. So that's all. Thank you.
I'll just add one thing, if you don't mind. I mean, there are some instances, and I'll just highlight one, where like the Michigan Court of Appeals just upheld a conviction of a person who intentionally burned down their home in 2019, and then made an insurance claim, to recoup the loss. And so, something like that, it's hard to say, like, if AI, could catch something like that. And our fraud investigation unit played a, large role, in that, so.
Yeah, again, it depends on
Yeah.
what behaviors, characteristics, others that have been convicted in similars, and you look at it at the front end, right? I mean, like a driving record or something, you have that information available. So, thank you.
With that, we'll go over to Rep. Fitzgerald.
Thank you, Chair. Thank you for being here. Appreciate the information. I appreciate also being provided this 2024 Fraud Investigation Unit Annual Report. I have a question about some of the data in here. I just want to read from the fraud reports section on page 4. Not every fraud report received provides sufficient information to demonstrate actionable fraud or criminal activity. Each fraud report is carefully reviewed and evaluated based on criteria, and it continues. What I look at on page 5 then is that from July of 2023 to end of June 2024, we take in nearly 3,800 complaints. We close nearly 3,600. We open 56 units, or 56 investigations. What I'm looking at here is two things. Where are the other 131 cases that would not round out to almost 3,800? Are those pending? Are those actively being investigated? Where are those other 131 cases? And I'm also wondering about the fact that I understand the disclaimer here saying that these reports may include previous reports from other years. My question is, I mean, if I'm just the layman and I'm looking at this, we're talking about just over 5% of all cases actually move forward. Knowing that there's not enough information upon intake, upon notice made to FIU, what is that review process like? I mean, this seems like significant time spent reviewing all of these cases to then close nearly 3,600 of them without investigations resulting in charges. There's lack of evidence. I'm curious to know maybe how that review takes place, and then also whether or not upon intake, recognizing there seems to be something here, what does that form look like? Meaning, can you go back to them and say, is there additional detail that you have about this case? Is there more that we can understand is happening in the background of this or has changed since? Can you just explain this intake and the review?
I appreciate the question, Representative. I think so. Circling back to your first point regarding, the reference to fraud reports received that do not contain sufficient evidence to move forward, whatever the case may be. That's not an explanation of the totality of those cases or those fraud reports that we receive that are closed without further action. That's certainly a variety. We do have the ability to, in particular, those fraud reports that are received directly from industry, for instance, we do have the ability to reach back out to the carrier that made the initial report to seek additional information in order to complete our review. The reality is, we have limited resources within the unit itself in terms of being able to conduct investigations, and so we have to be particularly focused on those reports of insurance fraud that are potentially most impactful. We're obviously primarily focused on, ring activity or large dollar instances of fraud, if you will, or those specific instances that would be particularly impactful to the industry as a whole. And so that's part of the analysis that we engage in terms of determining which fraud reports we're going to carry forward and conduct a full investigation. The other piece that is probably not highlighted within the report itself is many of the fraud reports there may be overlap. In other words, several fraud reports might be combined into one specific investigation that's opened. That's not necessarily reflected in the raw data and the figures that are kind of set forth in the report, in the table itself. Those are just kind of a flavor of I guess, some additional factors that are considered.
So I'm hearing that maybe there is some triaging or some selective engagement that takes place in order to make sure that there is a maximum benefit or maximum impact to some of these cases then?
Absolutely, absolutely, yeah.
What then happens to the cases that are maybe worthy of investigation, but it is an outlier case where there's one potential fraudulent action taken, not worthy of the FIU engagement? Does that then go to the carrier to say, hey, this person's going to be on a cancel policy, we're going to non-renew them, we're done, they can try and move on? Or is there some sort of mechanism still by which they're held accountable for those fraudulent actions?
Sure. So I guess, one principal aspect, you mentioned going back to the carrier. I think, Jen, you can correct me if I'm wrong, I think approximately 80% or thereabouts of the fraud reports that we receive presently come from industry. So as far as, it exists, it lives and breathes with the carriers themselves that are making the reports. So there's really not necessarily anything to send back to the carrier, because our process operates independent of whatever process the carriers themselves might have in terms of investigating suspicious activity or fraud activity. And the carriers themselves have their own avenues to pursue remedies on their own behalf, be it civil or what have you. And those exist outside and independent of what we do. And so from that perspective, I think there is the ability for them to carry their own cause forward however they deem fit. I wouldn't necessarily characterize those fraud reports that we review as being somehow unworthy of our time or effort. I think, as you alluded to, it's a matter of maximizing our resource allocation in a meaningful way and focusing on the right types of fraud reports and investigations that would be the most impactful. We do have occasion to refer matters that we think are significant but that we don't have the resources to allocate. We can refer those to other law enforcement agencies and our external partners in that way. It really depends. It's kind of case specific as to what presents what's in front of us. Mm-hmm.
And thank you for that. And just going back to that answer, so if you do refer a case out to local law enforcement, are any of those numbers reflected in the numbers in the report? And then if so, would that be under like fraud reports that are closed? Sorry, it's page 5. That's what I'm looking at.
Do you know?
Yeah, this is not on this page. One sec.
I think we have numbers in there of like number that are convicted during that time period, and the number that are closed, and some of those, and you can correct me if I'm wrong, we do refer some of those to the AG as well. So there's a kind of a multitude of.
Yeah, in response to your specific question, Mr. Chair, I believe the numbers in the actual report are reflective of those matters that are referred for prosecution, either to the Attorney General's office or to local prosecutors. In terms of any matters that might be referred externally to other law enforcement agencies for further investigation, I don't think our numbers or stats really reflect that number or what that picture looks like or what happens, certainly what happens after we refer those to those entities. I mean, they're free to do their own process, obviously.
And those are on page 6. The top of
On page 6.
Yeah.
Oh, thank you. I guess I could have flipped the page. So my real question was, can you describe the types of cases that you're seeing? What are, are they arson? Are they stolen vehicle reports, healthcare claims? What types of cases are you seeing?
The type of cases that we primarily deal with right now is going to be in the arena of auto, so stage accidents, which ultimately lead over to clinics where the treatment may or may not be happening. That's the majority of our casework right now, so just trying to pinpoint a good avenue to enter it, because we also have some attorney involvement in some of these cases. We're just currently working through that, but that's the bulk of our caseload right now.
And as you know, I've worked some assigned claim cases when I work for a private investigation firm, and they're very complex. And so I know what you guys have to go through with trying to prove intent and find that circle of fraud, and it's tough. So thank you, and I obviously encourage you to keep at it. But I do think we have another question from Representative Aragona.
Yeah, thank you, Mr. Chair, and thank you guys for being here. Appreciate it. Actually, I had some questions along the same line. So, just to be clear, kind of building off what Rep. Fitzgerald was asking, the 131 cases, that's mainly going to investigators of some sort, yes, at a local or county level, right? Is that what you're saying? Am I understanding your answer correctly?
I believe so, from the building off of what Representative Fitzgerald had mentioned. I think there's a kind of like, it's a very complicated, and each cases has their unique circumstances. And so, from my understanding is that, the fraud investigation unit looks at those individually and makes those decisions for the avenues that we have in front of us. So I don't know if you want to add anything else to that.
So, okay, yeah. And so, am I understanding the workflow correctly in that, you have a complaint, there's an investigation, you might find some type of settlement, or you find like, all right, well, this is criminal, so I need to get it to a prosecutor, whether it's a local prosecutor or the attorney general, something like that. So it's kind of we can take care of this internally, it needs to be taken care of externally. Is that correct?
I'll mention it, and then I'll have my team here too. So we receive complaints from multiple resources or sources. So between law enforcement, the FIU can be used to assist with them per their request. Also, we have like consumer victims, insurance companies, and then we also have a online complaint, like a website for online complaint forms to be filled out. In terms of, I think maybe the workflow, I will, if you want to talk to a little bit of that.
So to your question specifically about how the cases are triaged when they're deemed civil and then criminal?
Yeah, it seemed to me how you were talking about the actual workflow of, a complaint comes in. I think Rep. Fitzgerald used the term triage of like, you're going to take a look at it. It seemed to me that once it gets through the workflow to a certain extent, you guys need to, I guess I'm asking just to make sure I'm understanding correctly, that a certain extent you need to understand, you're trying to figure out whether it's criminal or not, in which case you then pass off to like a prosecutor or maybe a law enforcement agency. Is that correct?
Yes, that's
Okay.
correct.
Or you handle it internally and try and come to some type of resolution with the person that you're, I'm going to say, going after.
Correct.
Okay. And then the deeper questions, two more questions, Mr. Chair, if that's okay. How long does that usually take on average? I know that's kind of a tough question, and I know that from what I'm seeing here, I mean, you got fraud reports received, fraud reports closed. I mean, those are the two largest numbers that you have. So I'm assuming, I'm making an assumption here, and please correct me if I'm wrong, but, it seems like you're getting reports, there's not enough here, we can't do anything, close that. The reports that you're getting that you're actually coming to some type of resolution, or you're figuring out that there is actually a criminal referral involved, those types of cases, how long are those in your system?
So that can also vary depending on the carrier and what initial information they discovered to even refer it to our unit. On average, if it's for me, I say solvability. So like if the information's there, we can put it against criminal law. It can take us around 8 months, and that's pretty quick for us to process the case to get it over to prosecutors. And then from that point, if they need additional work done, it comes back to us and we continue to work. So it just really depends on the type of case that comes in.
Okay. And then I also see on page 6, the $2 figures. You have restitution ordered for that 1 year time period that you're looking at, that sample size there, and then fines costs ordered. I mean, you're using the terms ordered, so on those two figures, how much of that has actually been received? I mean, ordered doesn't mean that it's actually been given up, right? So has that, what's the success rate of actually getting those dollars?
So, I mean, that's characterized in terms of ordered. That's ordered by a court,
Right.
So that would be administered through the court process, and I don't know that we have necessarily, we don't necessarily get the follow-up in terms of what that looks like in terms of the actual restitution paid or the fines and costs themselves. I don't know that we get that data reported back to us from whatever court we may be involved in a particular case.
Okay. All right. The reason why I'm asking is if somebody's found to be fraudulent, all right, the court orders $20,000, but then they don't pay. And then, the company has to go after them for, look, you've been ordered for this $20,000. Then, what good has the process been, right? And I'm not putting that on you guys, but, it seems like we would want to make sure that once it's been ordered, all right, guys, you got to pay up. So thank you very much.
Minority Vice Chair Carter.
Thank you, Mr. Chair. You know I was going to try to stay out of this, but I want to go back to Rep. Tisdale's question. I believe it was Rep. Tisdale that brought up AI. I attend a lot of conferences in COIL, in CSL, and NIAC. And all of these organizations are using AI. Now, correct me if I'm wrong. Did I hear you say that at this current time, FIU is not using AI as a predictor?
Correct.
Are you anticipating it? With these other organizations actually implementing, in some cases, using it as a filter?
I think we're open to discussion about the use of AI as it is an evolving technology and making sure that it's, used appropriately and, effectively. So, I think we're always open to having that conversation about where it can be applied and used.
All right. Well, thank you. I think that wraps up our questions. I appreciate you being here. Look forward to talking to you guys soon.
Thank you.
Okay, next up on the agenda is a presentation from Sean Stevenson of the Pharmaceutical Care Management Association. Thank you for being here, Sean. The floor is yours whenever you're ready.
Thank you, Chair Harris. Thank you, Ranking Member Carter. Members of the committee, good afternoon. Good to be here in front of you. I look around the panel, and I know, thanks to Carla, we have made an effort to visit all your offices and answer your questions in advance, but I do appreciate the opportunity to be before you today, as I know the chair is going through an extensive list of interested parties and stakeholders to talk about healthcare costs. Specifically, seems to be the theme going around this committee, so I did appropriately put my presentation to talk about PBM's, the intersection of care and cost savings. So real quick, for those who may not know, here's a list of all the PCMA members. Again, PCMA is the National Trade Association for this country's PBMs. We have 20 members of the association, but everyone should know that there are about 73 full-time operating PBMs throughout the country, some boutique, some regional, but as of today, PCMA has 20 of those. And under that umbrella, we cover 289 million lives. That's about 3/4 of the population of the United States. One thing I always like to point out is that we are a service to businesses and employers and union groups So we are not mandated, but again, over 3/4 of the country choose to use a PBM because of our proven ability to provide cost savings. So what is a PBM? Quite simply, a PBM is a healthcare company hired by insurers, employers, and government programs to administer their prescription drug benefit. So what does that mean? We focus on lowering prescription drug costs, and how do we do that? One, we negotiate rebates from drug manufacturers. Two, we negotiate discounts from pharmacies. Three, and under those two cost-saving measures, we're able to save approximately $1,154 for every covered live under this country. So the value proposition for everyone to use a PBM is there. And these savings are passed on fully to the control of the payer of the system. So when they receive those savings, they get to decide how they want to disperse that and realize that savings to their employer group. We also offer services that benefits patients, such as home delivery, adherence programs, and do drug reviews. We also help manage the high costs of specialty drugs, and we are, the last discussion was talking about waste, fraud, and abuse. We are always in that program, with our auditing of claims and ensuring that no one is being overpaid or being duplicated, but at the right amount. So real quickly, who hires a PBM? Again, I've got 4 pictures up there. It's private sector employers, public sector employers, commercial health carriers, government programs, union Taft-Hartley plans. While employers could negotiate directly with drug companies and pay prices each pharmacy charges the general public, nearly all choose to work with the PBM because of the value that our companies provide them and the patients that they cover. Over the next 10 years, PBMs will save all these entities to the tune of $1.2 trillion. So how do PBMs work? These are just some of the tools. I'll go through them relatively quickly because I wanted to be mindful of everyone's time. But again, the first thing I mentioned was drug rebates from manufacturers. These create savings for payers of plans. Ultimately, the payer will decide how to use those rebates. Mail pharmacy services, that's exactly what you think, how everyone gets Amazon packages delivered to their house. That's how mail order pharmacy works. For when it makes sense and to the at the patient's decision to do that as well. And employers love this option because it saves a lot of money. Mail delivery is expected to save Medicare Part D and Medicaid managed programs over $100 billion in the next 10 years. DOD and CMS found that their mail order service costs less than retail, and it saves them 16.7% in the TRICARE budget and 16% in the Medicare Part D budget. And if you're familiar with those programs, that's 16% is a lot of money on billions of dollars in prescription drugs for our men and women in the military. Specialty pharmacies, specialty pharmacies offer higher discounts than average retail drugstores, and the value proposition there is they can save $545 billion over the next 10 years. Next, I have adopted pharmacy networks. Adopting pharmacy networks can lower drug spending in insurance plans by about 2%, as we've seen in the Medicare Part D market. Back when we looked at the stat recently in 2017, roughly 50% of all commercial plans had some sort of preferred network. Again, the value benefit there of providing savings. Formulary management. Formulary is just a fancy word for a list of drugs that are covered by your health benefit. Sometimes they, and again, these are created as a cost savings measure to the payer who is providing the benefit so that they can manage costs. Claims processing, PBMs were born out of claims processing. 40 to 50 years ago, it started out, employers didn't want to handle processing prescription drug claims. PBMs were born out of that, so that's something that we've always done since the beginning. Drug utilization, when you think of that, I want you to think of, you hear the words prior authorization and step therapy, and those are, again, 2 tools that plan sponsors decide to use, again, to help control costs. Disease management and adherence programs. The best way to talk about that is to provide you just an example. If you are a diabetic patient, PBMs can offer tools such as glucose monitors and can read in real time your blood sugar levels. They'll know to be able to help manage your disease when you have an upcoming prescription that may need to be refilled in the future. So that is how we do that. So again, I created a slide. What do we do for patients? Again, one thing that you might not be aware is we reduce medication errors through the use of utilization programs. As I talked about, we negotiate savings with drug manufacturers. Just talked about the coordinating health part of the aspect too, and again, promoting drug therapy and patient adherence in the diabetic program I just went through. So when you look at the numbers, PBM's impact for patients. 4 numbers I want you to highlight. 1 billion medication errors that will be prevented by PBMs over the next 10 years. As I stated before, $1,154 is what the average person will be saved by PBMs. Patients, 40 to 50% will save on all their prescription drug and medical related causes. And 440,000, that's a new metric that we're putting out there. That's PBMs improve drug therapies and adherence in diabetes patients to reduce complications of that amount of patients and heart attacks annually. Next slide, I think a lot of you I've shared this with in the past, but it does worth mentioning going over once again. In the total dollar drug spend of a prescription drug, 65 cents goes to the drug manufacturer, 25 cents to the pharmacy, 6 cents to the PBM, and 4 cents to the wholesaler. So if the public policy objective is to lower prescription drug costs, you got to look at where 90% of the spend is. That's just the raw data and the raw numbers, and again, I would put that up there for your consideration. Real quick, this is just a third-party hand from renowned economist George Ford, who put out a recent study that said, looking at, again, the value proposition of PBMs. Just a couple stats up there for you. From 2007 to 2018, list brand drugs rose 159%, while net prices only mean 60. Again, that demonstrates the value of PBMs, bringing down that low net cost. When drug costs have almost, more than double than that, we're again putting pressures on getting rebates and price concessions all across the ecosystem to help keep that net price lower. Rebates and Medicaid increased 40 to 70%, and 23 to 51% for other payers. Again, PBMs are always introducing therapeutic alternatives, which result in cost savings there from a name brand drug to an alternative. And again, I've talked about extensively the value of mail order provides patients. And again, his stats suggest that the average mail order being 27 and 53% below the average cash price that customers would pay at a pharmacy center. Real quick, just a quick look at Michigan specifically, since we're in Lansing today, and to give you an overview, here in Michigan, PBMs cover 9.3 million lives. Over the next 10 years, Michiganders will save $33.25 billion, and specifically for the Medicaid portion, it'll be $2.25 billion. This is my last slide. I put this up there. I've 21 laws that have passed, a lot of them being contained in what I would categorize as the PBM omnibus bill from 2022. And you have this information in your slide deck before you, so I'm not going to go through all these. But again, I want to highlight this point. If the public policy objective with the PBM reform bills from 2022 was to help lower costs, I would simply ask the question, are you hearing that prescription drug costs are lower after the enactment of this bill and regulatory structure surrounding PBMs? And I don't know the answer to that. I would assume it would be no, but before you take any more action, hear us out and learn more about what we do, because again, with these 21 provisions contained in legislation, I don't think it has, achieved the goal of reducing prescription drug costs. That's my presentation. Again, I've met with a lot of you over the past couple of years. It's good to be in front of you today, and I'm happy to take any questions, Mr. Chair, that you and the committee have at this time.
Thank you, Sean. I really appreciate you being here. And, again, as we're really diving into the cost of healthcare, it's important that we're looking at all these different avenues.
Absolutely.
So let me ask you this, because as you know, this is a topic that has come up a ton, and this committee is no strangers to some of this.
Yeah.
So I'd like to go back to your graphic, the little pill graphic,
Yeah.
if you would. So I know you have percentages drawn out here, and one of the things I know that this committee has looked at is not only healthcare as it relates to health insurance, drug pricing, what have you, fraud, as we've just heard. On this graphic, how would you say 340B plays into that program? How does it play into this and drug costs? I saw the look on your face there, Vice Chair.
My days. So, thank you for the question, Mr. Chair. Again, in the dollar spend of how a dollar gets spent on prescription drug, I really can't speak to the 340B program. That's between entity and the pharmacy, and I don't know what the makeup of that would be. This graphic simply suggests when a therapeutic is, and any of your constituents get a prescription drug, the breakdown for all the players within the industry is that. Now, hospital pharmacies is, I guess, what they would be categorized in the 25%, to best answer your question, because it's the hospital pharmacy that would be the 340B entity, and that would be captured in the 25%.
I could probably ask you a ton of questions, but I want to share the wealth here. Rep. Fitzgerald.
If you can actually go back one slide, my question is regards to the PBM's impact by the numbers. Yes, that right there. I'm curious about this $1 billion medication errors PBMs will prevent over the next 10 years.
Sure.
I'm curious. Are you saying that there's 100 million per incidents per year where there would be maybe a bad drug interaction with what would be in that person's prescribed portfolio, or what are these errors that are being corrected by PBMs?
Sure. Thank you for the question, Rep. Fitzgerald. So, can be a lot of things. Can be a script error. If there's any doctors in here, please forgive me. But when I went to the doctor growing up, they wrote it down on a piece of paper and it looked like that. And then, sometimes it was hard to decipher. And when you call in prescription drugs, errors are made. When you dial in prescription drugs, errors are made. Quantities can be misconstrued. The potency of it, the percentage of the drug, could be an error. So just like when you take Advil, its prescription drug strength can come in like the regular 200 milligrams, or you can buy the extra strength at 500 milligrams. And so it's little errors like that get caught that equate to about 100 million a year that happen. But it can also be price, can also be wrong, could be wrong person. It rarely happens, but when you go up to the pharmacy counter, they always ask you, name, date of birth, address, etc. It's to ensure all that is accurate and you're getting the right drug at the right dose at the right price.
And staying on this same slide, the $1,100 per person per year saved on prescription drugs, I assume, is that an average nationwide?
Average nationwide. It's not specific to Michigan, correct?
Is there a median number? I find that number to be strikingly high for, if you will, the average person. We see it all that we're in insurance, but I'll go to financial services. I see it all the time with 401k balances. Sure. The difference between an average 401k balance and a median 401k balance.
Sure. I can look at that for you, but yeah, that's the number that we use based on, again, when I was describing rebates, price concessions, and savings generated that we do on behalf of our clients. The average comes to about $1,154 per life.
Would this also include hospital-administered drugs, such as, I don't know if for
It would.
a friend of mine just had a baby this morning. Congratulations, Katie and Max.
Congratulations. Yeah, that's awesome.
If, for example, the epidural, the Pitocin, all those other things included would also come through that $1,100 figure.
Well, just to back up, when you go to the pharmacy, that is different than being administered in a hospital setting, so I want to back it up. It would not be included in that number.
Okay. That's what I was wondering, is whether or not those hospital-included drugs are there.
Yeah.
Okay, thank you.
Thank you.
Representative Aragona.
Thank you, Mr. Chair. And thank you for being here, sir. I know there's been some talk at the federal level regarding some PBM reform. I just wanted to give you an opportunity. Did you want to speak to that? I know, you probably could speak to it for a while, but did you want to take a couple of minutes just to speak to that?
So it's being debated right now.
Right.
Congress is considering a couple of measures. My understanding is that they have not coalesced around any framework yet, but to be determined. And being a state government affairs person, I focus on Wisconsin, Michigan, Ohio, Virginia, and Illinois, but am aware of the debate there, and that's for the federal lawmakers to work out. And I know CMS and HHS are looking at various things, again, all under the scope of cost savings and paying more or paying less for prescription drugs. So, but it's to be determined. I know I saw the Senate Majority Leader said we're not leaving until we have our vehicle. I don't know if we will be included in that legislative vehicle at this point, but it is ongoing, and our federal folks do a great job of informing members of Congress about the value proposition of PBMs.
Okay. And then a couple of weeks ago, we had another presentation, and there's a chart that showed a number of different companies and the vertical expansion through the drug space on where many companies had purchased through PBMs up through almost to many of them even to the drug manufacturer, and then basically all the way through even to the pharmacy level. Do you find that a concern at all, that there's basically one company going all the way from the drug through the healthcare system all the way to the patient level? I mean, should we?
So that's been looked at by the FTC, and mergers and acquisitions are approved by the FTC to ensure competitiveness within the market, and the FTC has approved those. And I guess that's how I would answer that. I mean, they look at it a lot more extensively than members of Congress, and look under a fine scope, and if they think there would be a market imbalance as a result, they would not approve the merger.
Yeah, I'm not looking at it from a trade aspect. I'm just looking at it, is it good for the patient?
So everything a PBM does is help lower the prescription drug costs for our payers, and again, our payers are governments, private sector, public sector, Union, Taft-Hartley. Those are our customers that provide the healthcare benefit to their employees, which are the patients getting the prescription drugs. So all the cost savings we generate through rebates, price concessions, putting policies in place that can help reduce costs, are all at the benefit of the payer who provides the benefit, the best ability they can for their employees to have their health insurance.
Okay. All right. Thank you.
Thank you.
Vice Chair Carter.
Thank you, Mr. Chair, and thank you for your testimony. And my question actually piggybacks on Rep. Aragona's, because I was going to ask you to explain vertical integration. I was going to ask you to say that what role does PBMs have in it, and then also my final question would have been, does PBMs have control over who has access to formularies?
Thank you for the question, Rep. Carter. So I'll just go back to, who is PCMA here, and we are multifaceted. Not everyone is vertically integrated. PBMs are currently evolving and finding boutique markets to make their placehold into this ecosystem. So again, while some members choose to vertically integrate, not all do. It might be cost prohibitive to do it. It might be advantageous, but in what you will see as a result of vertical integration, and it's just not exclusive to PBMs, but a lot of sectors in the healthcare industry is the objective of cost savings. And in the onset, I said, PBMs will always, try to find savings and efficiencies to provide prescription drugs at a lower cost, and if it makes sense to vertically integrate, they will take those steps. But again, that's not, it's a market decision. It's not, there's no right or wrong answer to it, but again, some choose to do it and some don't.
Thank you, Mr. Chair. And the follow-up,
Yeah.
which is concerning to me, it's been alleged that PBMs have control over whoever has access to the formularies. Can you substantiate or negate that statement?
Yeah, no, absolutely. Thank you for the question and the follow-up, because formularies are, again, a tool that employers will use to provide prescription drug benefits for their employees. So the payer, your health insurance, for example, Representative Carter, is the state of Michigan. They have a formulary. They have developed a formulary. Formularies determine what drugs are covered, what the copay will be, and the cost. So it is up to the employer to determine which drugs make it onto formulary and not the PBM. That decision is strictly made up to the person paying the bill, in this case the state of Michigan, or the health insurer. So it is not the PBM that determines which drugs go in and are out of formulary.
I appreciate that explanation. Thank you.
Thank you.
All right, I guess I have one follow-up question for you.
Excellent.
So, just because you haven't been in the hot seat long enough. So, there's a conversation around healthcare and transparency. I think we've talked before about transparency in hospitals, in pharmaceuticals. What are the current transparency requirements by PBMs?
In the state of Michigan?
Yeah, or federally.
Yeah.
Like, how can people access that
absolutely.
information?
So there's a lot of transparency measures in place to the federal government, and sometimes when states take action to do more, it is often redundant because CMS requires a plethora of reporting for compliance and participating in federal programs, which our members want to ensure that they're able to do and provide any and all information to the federal government to be as transparent as possible. The only you want actionable transparency. So people that are making the decision, that are buying the plans, we want to give them that information. So what your costs are going to be, what are the drugs that are going to be covered under it, what are the copays going to be. All that is provided to the payer, before they do a contract for pharmacy benefits. Like the state of Michigan, they will put out an RFP for pharmacy benefits, and they will say, we want to know the following: the price on X, Y, and Z, and we want a report that says you have to do it 4 times a year, twice a year, annually, whatever it may be. But I guess, to answer your question, all that information is available. We make it available. It is up to the plan sponsor to say, I want the following, and we're always happy to provide that. So as transparent as possible, as to the liking of the person who's paying the bill.
And is that information only available to the payer, or is that available publicly or to the legislature as we're reviewing these types of things?
Sure. So if it would depend, so again, when you respond to an RFP, each RFP is going to be unique. So if the state of Michigan, which covers, how many employees we have in the state of Michigan? I don't remember. Like 200. Let's say it's 200. Let's say it's 100,000. That RFP is going to look substantially different than the person that puts out the RFP for 50 of its employees. So the costs are they're going to be different, but we're going to make that transparent, absolutely.
So, and just a follow-up, so when we're looking at transparency data and whatnot, and we're trying to evaluate kind of where the state of healthcare is, right, and the cost to the eventual consumer, are there things like with PBMs, what percentage manufacturer rebates and discounts may be retained by PBMs versus passed on to, say, health plans or the actual consumer? Because I think this committee's heard a lot where a lot of these discounts, and I don't care if, again, hospitals, pharmacies, whatever, how is this getting back to our taxpayers here in Michigan?
Yeah, great question. And just to talk about rebates for a moment. So when a PBM gets a rebate from a drug manufacturer, it goes to the payer. So, again, for everyone's insurance here, it's the state of Michigan. And the state of Michigan says, what do we want to do with this? A couple options. Do we want to reduce everyone's premiums? Do we want to present it at the point of sale for specific drugs and specific individuals? Do we want to increase benefits? Those decisions are all made to the payer at that moment. Now, where we would be hesitant in showing how much we get for a rebate on a specific number, and we're happy to report in the aggregate, what you want to be careful of from a public policy perspective is if you mandate it to make it public, drug manufacturers will know the discounts that they are providing, and as a result, they may lessen their rebate amount if they know that their competitor is offering the exact amount that their customer is offering. So, for example, rebates only happen when there's competition between two therapies. So, drug X and drug Y are competitors to each other with different drug manufacturers. Drug X, has previously offered a rebate of $500, and drug Y doesn't know what that amount is, so they have to guess. If I want to win the business, I might want to try to go lower. Now, if I know drug X is $500, I might only undercut them by $50 and say, all right, I'm going to offer a $450 discount. Whereas if it's in a black box like the way it should, I'm guessing. So I really want to win the state of Michigan business. So I know roughly my competitor's doing $500. I'm going to offer $300, $200, or whatever. It's a guesstimate, and that's the way it should be. And that would be the only time you wouldn't want to invite tacit collusion.
Sure. But on that aspect, as we're looking at all the different narrow facets of healthcare, right, and we're evaluating things like there's talk on PBM reform or 340B reform or what have you, name it, and there's some talk about reform. So as we were trying to evaluate that, I mean, is there something we can see where PBMs, which I've heard referred to as middlemen, and that's probably, maybe an obscene way to put it, I'm sorry, but is there a way to look at what are the PBMs getting out of these transactions percentage-wise? Like, what percentage are the middlemen keeping on the rebates or discounts versus the payer or consumer?
Yeah.
I mean, there's got to be a profitable side of this, otherwise nobody would be doing it, right?
So let's back up that question just a little bit, and let me say this. So there are three ways PBMs are compensated traditionally, and it's a combination of the following. One, rebate retention, a percentage of the rebates. Two, spread pricing. Unfortunately, not in Michigan because that was banned back in the 2022 bill, but a form of spread pricing. Three, an administrative fee. And it's some combination of those that a PBM gets compensated. So, again, it's up to the plan sponsor to say, look, I don't want, I'm for PBM services, I'm happy to provide you administrative fee, and that's negotiated between the payer and the PBM. Some like that, some like spread pricing, some like rebate retention, like, hey, if you extract X amount out of rebates, I'd like you to keep that as a portion of your compensation. But ultimately, including the state of Michigan, including employers, union Taft-Hartley plans, et cetera, they determine the amount and the percentage of the rebates that go everywhere. I mean, it can only go to those three entities, and it's up to the payer to decide how those are used. It's exclusively up to them, and that is always transparent to them when they sign a contract.
But is it transparent to the public, or is it?
Do you want
or is
it?
it purely just between you guys?
It's
and the
business
payer?
to business, so
Okay.
it is not what it would not be publicly available, I guess.
Gotcha. Okay, I appreciate the answer.
Somebody else is ahead of me.
Rep. Fitzgerald.
Thank you, Chair. My question has to do with independent and chain pharmacies. With regard to reimbursements to those pharmacies, I'm hearing that there are challenges with regard to reimbursement rates and potentially being under reimbursed in those sectors. Can you explain
Sure.
how that might be the case?
Thank you, Representative, for the question. So everything's done in a contract. PBMs and the pharmacy in this transaction. Sometimes independent pharmacies will use a PSAO. That's a big fancy acronym for Pharmacy Service Administrative Organization. And what they will do is aggregate all the independent pharmacies and leverage their numbers to get better prices on prescription drugs. So depending on who it is, but again, between the PBM and the PSAO, those are all flushed out. So that is agreed to. The pharmacy signs that contract and understands what those reimbursement rates when they sign that contract. To speak to your point about being under reimbursed, so negotiations for prescription drug reimbursement are done in aggregate. And so what does that mean? You take, let's say, 100 drugs at a time. The net result of those negotiations often mean a net profit of, let's say, 8% to the pharmacy. So they're going to lose 2 cents on this reimbursement, 10 cents here, but they're going to get 20% on a drug that they often dispense and at a greater frequency. So the greater sum means a net profit for the pharmacy. But again, pharmacies agree to that, they understand that, and they sign those contracts willingly. So, but is it true that they can be under reimbursed for some drug products? Yes, but it means that they're making up for it being at a higher rate with a more frequent drug.
And our final question is going to be from Vice Chair Carter.
Thank you, Mr. Chair. And Chair brought up the rebate process, and I'm going to make this quite simple. I think I have the answers because I'm looking right at them. But the rebate process, once again, if a manufacturer comes to you, to a PBM,
Yep.
Do you negotiate with them with deeper rebates for better place on the formulary?
Better placement on the formulary, correct, yep.
So in other words, you recommend to them or you negotiate with them for a better place, even though the price of the drug isn't cheaper. And then on the other end, it's like the payer, are they given information of all possible people that they can use, or are they given information of who you refer to them? So once again, the middleman or the person in the middle of the PBM has control on both sides, which is the payer and the drug manufacturer.
So let me answer the first question, the first part of your question first. So PBMs want to provide the lowest net cost of the prescription drug. So let's say you have two therapies, two drugs. One costs $100, one costs $1,000. If we get a rebate for the $1,000, like let's say $950 rebate, that $1,000 drug to the patient is $50, and that's why it's going to get favorable placement on the formulary versus the drug that costs $100. So that's the agreement that is made there. And to your second question, can you just repeat it for me again real quick?
Because you said the payer has control
Correct.
of what
Yep.
they receive.
Yep.
But is that a recommendation from the PBM, or are they given several options to?
They're given several options, and ultimately it's up to them.
Okay. Thank you.
Thank you. I don't see Randy here today.
He's here. he's kind of giving me these questions down
No.
there.
I don't doubt that for a moment.
All right. Well, Sean, thank you for being here and
Mr. Chairman, committee
and
members.
spending your time with us.
Thank
I
you very much.
appreciate it. All right. With that, can I have a motion to excuse absent members? And the vice chair will do that. And without objection, absent members are excused. And with no further business before the committee, we are adjourned.